Hi, everybody. I'm Jacqueline Becker. I'm a clinical neuropsychologist and a health services researcher at Mount Sinai in New York. I just wanted to present something a little bit different today. This is a little less about treatment and a little bit more about a framework or a model of primary care integrated with long COVID. So I received some research support from these different sources. So as we've all heard in the past day and a half, long COVID is very complex, and it's a multi-system disease with high functional disability. And I think what's important here is that while the science has advanced substantially over the past several years, clinical care still lags substantially behind science. We still have, substantially long wait lists, fragmented care at best. There is still a lot of stigma, especially in primary care settings, under recognition of post-exertional malaise and POTS, and how to manage infection-associated chronic conditions like long COVID. And there are limited access to neuropsychological services where patients are often waiting over a year to get any kind of cognitive assessment and services that they need for disability evaluations a lot of the time. And underserved communities have a disproportionate burden in that regard, and they have the least access and often are the most impacted. And so what we did is we received funding from AHRQ to essentially embed a long COVID clinic in our primary care clinic that was existing at Sinai Hospital. And the focus was on improving access to care for minoritized groups. So primarily, we just, chose primary care because of the growing demand for long COVID care, and it essentially needed to be a sort of one-stop shop. Patients were already going to primary care physicians often first to get referrals to other places, but we really needed a multidisciplinary specialty clinic, and there wasn't enough of these sort of long COVID clinics for the demand of patients that we were seeing in New York. Most long COVID care is already happening in primary care, but, for the 15-minute visits and, pre-existing comorbidities on top of the multimorbidity of long COVID without any kind of structured protocol was really problematic. And again, minoritized communities were facing sort of additional burdens where they would come into primary care, were either dismissed or told to seek out referrals and have to sort of navigate these complex healthcare systems on their own. Which often resulted in more barriers like access to specialists, and insurance barriers. And so this sort of primary care integrated model allowed us to reduce fragmentation and delays in care through like streamlined referral care pathways that we had, and allowed us to really integrate social needs support directly into clinical pathways as well. So essentially the goals of our program were to expand access to comprehensive long COVID care, and specifically for minoritized communities in Harlem and South Bronx, to equip other primary care practices as well with the tools and resources to better support patients with long COVID, and to develop educational programs for long COVID care for providers of different specialties. And then we also evaluate the impact on access, patient satisfaction, utilization, quality, and costs. So our clinical model, again, is multidisciplinary. Besides just general internists, we have patient navigators who help with appointments and resource availability, insurance and disability support as well. Social workers who provide psychosocial support. They do group therapy, support groups, community resources as well, and work through social determinants of health. And then we have neuropsychology. So it's myself and a few neuropsychology fellows who do the assessment and tailored support for cognitive symptoms, and we help with disability evaluations as well. And so this seems like a luxury, but PCP visits in our clinic are 60 minutes. And so usually they'll do various in-office assessments, so, spirometry, 6-minute walk tests, et cetera. They're trained to do a cognitive screener as well, especially for patients who report any kind of brain fog or cognitive dysfunction. And if it's either below the threshold or the patient has substantial functional impairment, they'll refer to neuropsychology. And we've been able to streamline a battery of tests where we actually do the full interview and full testing in about 2 hours. And it's not necessarily the same day as the patient comes in, but we can accommodate for patients that really need that. We also help connect patients with clinical trials that are ongoing, or if they want to participate in any kind of research, we keep a repository of all of the local research. And then we coordinate specialty referrals. So we have sort of these streamlined pathways where we're able to connect them readily with neurology, psychiatry, cardiology, et cetera. And so I think this is one of the most important parts of this program, actually, is the long COVID education and community engagement. So we do biweekly lectures for internal medicine residents, and that really has been really important, I think, especially being one of the people who does these for medical residents, seeing just how much it's needed and how little awareness there is of long COVID and other infection-associated chronic conditions or post-viral syndromes, or even just the impact of the viruses long-term on brain health. And so these have been, I think, really, really important. We also do grand rounds and do different events for attendings for medical students, and we do trainings for neuropsychology fellows as well. We also partner with various community groups like AIR NYC and train community health workers to identify and triage long COVID, and this has also helped sort of streamline referrals into our clinic from the community. But it also helps people who maybe have still like a mistrust and don't yet want to come into a formalized setting. It allows us to train community health workers to provide that in the patient's home with people that they trust and they've known for a long time. And then we also engage people with lived experience to sort of assess reach and the effectiveness of our clinic, and to set priorities and think through things that are most important for them. And so we've been open for a little less than 2 years, and we've served about 412 patients so far. This is sort of the demographic breakdown here. So we've captured about half from underserved communities, which was our target, and the rest from other areas in New York. We've also had some people travel, which was a little bit concerning, but the age range is pretty wide, so anywhere from 18 to 96, but generally speaking, as we all know, long COVID tends to fall in that 31 to 55 age range in primary care settings, and so that's typically where we've seen patients, and the majority have been female. And the most frequently reported symptoms for the patients that come in were brain fog, fatigue, post-exertional malaise, shortness of breath, depression, anxiety, headaches, et cetera. So looking back at our metrics, the average time to first appointment has been about 31 days, or give or take. About 70 of those patients have required neuropsychological services and received them within 2 months, which if you compare with, neuropsychology services, which is over a year-long wait list, it's pretty quick. And all 70 of the patients that have come in, we've been able to detect actual impairment, which suggests that our triage model was effective. And 15% were connected to different referral sources. So physical therapy, 6% to neurology, 11% to psychiatry. But most, of the different presentations have been able to be treated by the PCP specifically. And so overall, just wanted to highlight that in less than 2 years of this model, we found that there were substantial improvements in access, particularly for these patients. We found that this model is scalable, sustainable, and adaptable. And again, just to highlight the training of clinicians, I think that this is a really important and often overlooked sort of area where, in order to reduce stigma and improve evidence-based care, it's not just about, us sitting in this room or clinicians who are already working with long COVID, but also training this next generation of clinicians to, be aware of these conditions at the very least, and also know how to identify and manage them. And, generally, I think this framework can extend beyond long COVID to other infection-associated chronic conditions as well. And, I think the sort of equitable part of this we showed is achievable, and even in resource-constrained settings. And so, I think this model just provides sort of a path forward to, hopefully improve access, reduce stigma, and provide equitable long COVID care. And with that, just want to acknowledge our core team, our patients, and our community partners. Thank you so much.